Good evening everyone, my name's John Bailey. I'm the Executive Manager for Hunter New England Central Coast Primary Health Network, and I'd like to welcome you to the 9th in our series of pandemic and COVID updates. I'd like to firstly acknowledge the traditional owners of the lands on which we're meeting and pay my respect to elders past, present and future. Tonight we're going to have a look at the role of primary care nurses during the pandemic, and we'll hear from a range of speakers who will give us a variety of ideas and inputs in terms of their context and their experience. Can I encourage you to send questions through on Slido, and the event is PHN9, so that's PHN9. And from there we'll be able to address the questions towards the end of the evening. So first up tonight we've got John Ferguson. John's an infectious diseases physician and a microbiologist, John Hunter Hospital here in Newcastle. So over to John. Thank you.
Thank you very much, John, and thank you for the invite to be part of this evening, which I'm quite interested to hear the experience of the primary care nurses that are on the program. I must say that I don't work in primary care, so I'm coming from a hospital base, but I've been asked to give you an overview of some of the infection control principles and I think a lot of this needs to be adapted to the primary care setting, and so I'm going to be listening very closely to what you have to say about your experience in recent months. It's been a very interesting time for all of us. So I liked this study, which studied how this virus was transmitting in China, and you might not trust information coming out of China. However, I do know that the WHO team that went there in February had access to just about everything according to them, and they were an independent team, and their report at the beginning of March tabs in with this report published more recently around case reports of outbreaks and transmission chains within China. And the bottom line here was that most transmission was occurring in households with index cases that were usually adults, not children. And the secondary place that they occurred was closed transport. So we'll come back to these closed areas and how they establish a risk for transmission. There was only a single cluster of 2 reported from an outdoor location. Now, a typical scenario, this is from a Chinese restaurant. What else? The Chinese restaurant was actually twice the size of this on a particular floor, and there was a pre-symptomatic case A1 seated at table A. All the guests were there for approximately 2 hours, and all the red circles are the secondary cases that occurred subsequent to that transmission event within the restaurant. Of interest, there was no transmission to other tables away from that ventilation, and no transmission to staff. So the cursory contacts the staff had did not transmit it. And this is very much in accord with what we call large respiratory droplet spread and contact spread. So A1, particularly moving around those tables, probably created opportunity for contact and droplet spread over those 2 hours, so it was an extended period of time. These are some salutary events from hospitals. We've just had one, we had one at the beginning of March in Manning Base Hospital, a COVID positive COPD patient with type 2 respiratory failure, managed for a long time, 3 days in ICU and ED, receiving nebulizers and BiPAP, both aerosolizing procedures, and we were in great fear that we were sitting on a big outbreak here. The patient was thankfully managed in a single room within the ICU with the door closed, but staff were particularly casual with their PPE, and not all of them most of them didn't wear eye protection. Lo and behold, we had no transmissions. We even screened all the staff serologically to prove that case after 5 weeks. A second event there is told about a large hospital ward, and there's a sort of an 8-bed area of that ward, close beds, where a patient with severe pneumonia was managed on oxygen, and that patient exposed 71 staff 49 patients, no acquisitions again. And lastly, a patient managed in ICU for 3 days with some very high-risk procedures with healthcare staff mostly just protected with surgical masks. I don't actually mention eye protection in that paper, but I'll say more about eye protection in a moment. But again, this is giving us assurance that there's not transmission at a distance. It's direct face-to-face contact, close contact that's important, and probably close contact for an extended period of time. You'll know that public health have about a 15-minute cutoff for close contact face-to-face. So it's not an infection that transmits through a cursory manner. One of the things that helps us in hospitalised cases is that by the time patients deteriorate, they're often into the second week of their illness and their viral load is lower. So it's an easier park to play on than perhaps in primary care, where patients presenting in the first 5 days of illness will have higher viral load and be more transmissible. Now, the value of wearing a surgical mask by patients or patients with infection is well shown by a couple of studies. This is just an example study looking at coronavirus and influenza virus, how this transmits outside the mask in people that are randomised to wear a mask or not, and looking at the exhaled breath collection to see if virus can be detected. And there's quite a deal of reduction, virtually 100% reduction in coronavirus. These were common cold coronaviruses going down to 0 with wearing of a surgical mask. So this is a sensible strategy for our patients in primary care, patients with symptomatic respiratory infection, to put a mask on them. Now, this complex slide comes from a very large systematic review that you probably saw in the media. It looked at a whole variety of interventions that were and their value in preventing transmission. And it used examples from COVID-19, SARS, and the MERS virus, so the other coronaviruses. They were able to quantify the amount that physical distance plays. And I think there was something like, I can't read the slide, but for every extra metre that there was a twofold reduction in transmission. Face masks versus no face masks, a very close, strong association there. And interestingly, eye protection, quite a few studies showing that eye protection is well worthwhile. And I think eye protection's often been neglected in primary and hospital practice, and needs to be part of standard of care in terms of self-protection. Now, when we come to looking at respirator masks, P2 or N95 masks versus surgical masks, the evidence is that they provide equivalent protection for droplet transmission. So at least 4 randomised trials summarised in reference to. The first reference there is to the larger American study looking at influenza transmission in an outpatient setting, showing that there was no difference between those randomised to N95 respirators versus medical masks. And in that study, they actually used fit testing to ensure that the masks had a proper seal around the face. And there was no signal coming out of that. None of these studies really mentioned hand hygiene and some of the other elephants in the room that were probably responsible for a lot of the transmission as well. Suffice to say that there's nothing magical about an N95 mask. They are difficult to wear for prolonged periods of time. They damage the nose. They're difficult to seal around the face. When I was fit tested, I thought the mask fitted me well, but the fit test showed that it didn't. It's a difficult thing to mould the mask correctly to your face. And so you're not really gaining that additional protection anyway, unless you are really serious about how it's moulded to the face and whether you've been fit tested as such. Now, when we look at the wider factors influencing acquisition, this is a very nice slide sort of quantifying the different dimensions. So the source strength, so they've got singing up there as a strong source, the turbulence and speed of air, the volume of the shared airspace, which I think is very important, and the time in that airspace, so the duration of care, and crowdedness and personal protection. So crowdedness brings in the factor of more likely to be a transmitting person within that crowd. and then personal protection last of all. So there's a lot of different factors involved in transmission events. And when we look to infection control, there's also a hierarchy that doesn't start with PPE, it really starts with the administrative measures in number one, standard precautions, and the environmental and engineering controls. And this is a traditional way of looking at occupational health and safety risks. You try to eliminate them, you substitute, you have engineering controls, administrative controls, and really PPE are the last thing you think about. So we can think this way with COVID transmission and risk. So triage, the sort of things that we're doing, of course, are to screen our staff, very important, eliminate presenteeism, staff who come to work sick, which is a very common factor in the past. Testing of patient screening, of course, which you're doing very well, I know, in primary care. Testing of exposed and symptomatic individuals, quarantine and isolation, of course. So these are all administrative measures. Standard precautions. So you'll know that figure from the Australian Commission on Safety and Quality in Healthcare. I think standard precautions are still not well understood by medical practitioners. I know nursing staff understand them well. I think we should be adopting a bare below the elbow clothing standard across clinical care. There's aspects of work clothing hygiene that I'm sure that you've looked to. Physical barriers for clerical staff and physical distancing at work. So in the Tasmanian hospital that had the large outbreak of COVID amongst the staff there, most of the transmission was occurring in huddles and handovers and tea rooms rather than patient to staff member. The staff were transmitting it amongst themselves. So I think we've got to become smarter about how we work. And then dependent on whether there's much community transmission in a society, you may then go to routine use of face shield or masks, etc., and establishing separate teams within a practice that don't intersect. Hand hygiene, well, there is magic in how it's done, and there's a 6-step WHO for how to put the hand rub on, and I don't see my colleagues doing this correctly. Hand washing uses a similar 6-step, and that's to ensure that the hand rub is covering all aspects of the hand. It doesn't actually take extra time to do those 6 steps because it's the time that it takes for the rub to dry, in fact. Risk-assessed use of PPE, part of standard precautions but very poorly understood by medical staff particularly. So the idea of using eye protection and a surgical mask when someone presents with acute respiratory infection. So it doesn't mean using those PPE for someone without respiratory infection who you're examining the throat of, but certainly if there's a risk, you should be using the PPE. Apron versus gown decisions are really done on a risk basis according to what sort of splash is expected and whether you've got exposed clothing that might be contaminated. Respiratory hygiene and cough etiquette, of course, you'll know that very closely. I'll skip over that. And then we get to additional transmission-based precautions. Droplet and contact precautions are really what is required in primary care. And there, the surgical mask eye protection are probably the front runners in terms of protection with this virus. Gloves, gown or apron. There's no magic about the gown. There's no magic about total body suits, head covers, shoe covers, etc. And they shouldn't be the standard of care, and they're quite wasteful. There's no magic with spraying the environment with bleach, the way we see on social media from various countries. It's quite amazing. That makes people feel better, I think. I think people have also been ingesting bleach in the US for certain reasons. And then environmental cleaning and engineering, relevant everywhere. And I think cleaning is really about people and understanding who cleans what and really empowering the cleaners as part of your team, as a high-level member of your team, because they are very important for keeping you safe. So you have to keep them happy, have to keep them educated, know what they're doing, so that you can have assurance that the surfaces have been cleaned to your standards. And I think I'm probably teaching you something you don't need to know, but I think it almost goes without saying, but it's incredibly important, the physical aspects of cleaning over disinfection. Disinfection won't work unless we clean well. We can't clean if there's a lot of clutter, etc. Engineering, of course, is having separate rooms, hard separation between patients, and good ventilation. So ventilation hasn't been to the fore with this virus. We haven't seen airborne transmission through ventilation systems, and we believe that that's not a great risk. The virus can be found in airborne aerosol, but it seems to be in insufficient quantity to cause infection at a distance. That probably relates to the infectious dose required by this virus, although that is not known as yet either. But from the epidemiological data, I think we can strongly say that transmission at a distance is rare. Craig Dalton, our local public health guru, has published this paper in the MJA, which I'd recommend to you, implementing sustainable low-cost physical distancing and enhanced hygiene. He has a whole section on workplace interactions and low-cost things that we can do to just hardwire safety for viral transmission. So that's all I've got for you today. I look forward to our conversations and the presentations from the other presenters. Thank you. Thank you for listening.
Thanks, John. We will no doubt have some questions for you towards the end, and I look forward to those coming in through Slido. And just a reminder that the Slido code is PHN and the number 9. Thank you. We're now going to hear from Denise Lyons. Denise is a primary care nurse working at Katara Family Practice, although I think that might be a bit of a furphy at the moment because from what I hear, she's somewhere up in the Torres Strait, and we're really testing the technology tonight. So Denise is going to talk to us about the APNA workforce survey results and the demographics in that, and then talk to us a little bit about team-based care in general practice, and particularly her experience. So thank you, Denise.
Thanks, John. I sure hope you guys can hear me. Greetings from Thursday Island in the Torres Strait. I am indeed here, got here on Monday, and started work today, working with Queensland Health in the public health unit, trying to keep that dreaded virus out of the communities up here. Thanks for the invitation to speak tonight about nursing, something I'm very passionate about. Before I move on, we'll go to the first slide, and I would like to again acknowledge the Indigenous owners of the land on which we all meet, the elders, past, present, and emerging. Particularly, I'd like to acknowledge the remote Indigenous communities and the unique challenges that they're facing. And any Indigenous nurses and healthcare workers out there, thanks for joining us. Go along to the next slide. The topics we're going to just briefly talk about tonight. I wanted to give you a few updates on the work we've been doing in the Health Pathways team, and then the COVID-19 impact on nursing workforce and the opportunities emerging from that. Then we're going to hear from some inspiring and motivated nurses from the Hunter New England region, some of our colleagues, and then just at the end talk a little bit about how the PHN can support practices to recover from the challenges that the pandemic has presented us with. So moving on to the next slide about health pathways, we have a brand new health pathway. That's the assessment and management of COVID-19 in children. That just went live on Saturday. A couple things you might want to check out there. It's got information for the Hunter New England LHD on the pathology testing available for little ones. Also, there's some New South Wales health information regarding home isolation for children, how children might have slightly different expected symptoms and disease progression, and some even includes information about protective measures whilst breastfeeding. So really anything you ever wanted to know about COVID-19 in children. I also just wanted to highlight where the star is on the slide there. The first place I always go to look when I log on to Health Pathways is the recent changes section on the COVID-19 suite of pathways. There's one called Recent Changes. This page provides you with information about what has changed or been updated, and so you can, at a glance, see what's the latest news, what's been updated, what's been changed. And like I say, it's the first place I go to look when I log on to see what's happening with this pandemic. And just on the next slide, a little bit of information about recent changes. When I say we, I mean Sandra. She's one of our clinical editors who does a whole lot of work on these pathways. And she's recently included some updates from the Clinical Excellence Commission around infection control and PPE. Some of the things that John just spoke about are highlighted there. And then there's a new fact sheet from the Department of Health regarding supporting people with disability during the pandemic, which is a good read. And the information coming out of research and the CDNA guidelines, we've updated the symptoms associated with the COVID-19 infection. And we're always trying to update the links and resources in the health professional and patient information section at the bottom of the pathways so that you have the most up-to-date information. So please keep using those pathways. On the COVID-19 information page, there's a new section on Aboriginal and Torres Strait Islander health, which has some really useful information as well. And on the next slide, there is up and coming, some health pathways updates on the immunization pathway. There's certainly a lot to be said here about the upcoming changes to the immunization schedule, but I'm going to leave that to Patrick, who's going to come along and talk a little bit later. Patrick and his team are just so good at supporting all of us in the business of immunizing. So just to say that there are significant changes that are going to be introduced from the 1st of July, and we are working hard to make sure that that information on the immunization health pathway is accurate and up to date by the 1st of July. Now, what about this virus? If you can move to the next slide for me, guys. This slide is a bit about what Australians are worrying about. So Monash University conducted interviews with 1,000 Australians in late March and asked what they were most worried about in relation to the pandemic. And in this image, you'll notice that the dark blue represents the worry a lot category. And this survey kind of showed us that more Australians were worried about the longer lasting societal effects of the COVID-19 pandemic, specifically that the health system could be overburdened, or that the country enter a recession, than they were about the more immediate changes to their own lives. So those two categories at the bottom of the page are interesting to note. I think this concern about overburdening the health system or catching the virus led to what we're going to talk about on the next slide. So we've noticed a reduction in the number of people accessing healthcare. So while telehealth has helped us to keep in touch with our patients, many practices have reported that they have seen a reduction in patient volumes as people are delaying those regular checkups, repeat prescriptions for medicines, and they're canceling their non-urgent appointments. So on the next slide, we can have a look at that in a bit more detail. This is a graph that came out of AusDoc. Sorry about that. And it just shows how regular attendances, this shows over the past 12 months. So from this April, this is published in April. So from this April to the previous April, the regular GP attendances, face-to-face visits that were made, there were 2 million fewer this past April than there were in the same April of last year, despite the fact that a lot of us were very busy providing flu immunizations and just trying to keep the practice rolling along. So at the same time, though, about 4 million telephone and video consultations were provided. So this has clearly been a really popular method of delivering care. So the Medicare statistics have confirmed that the telephone has been by far the most popular option for remote GP care. And those telephone consults have outstripped video more than 20 to 1. Those level B attendances, the most common type of less than 20-minute consultations, were the most common type of telehealth consultation, just as they are the most common type of face-to-face consultations. So, as I said, the telehealth helped us a lot to keep in touch with our patients. However, as you're going to see on the next graph, the chronic disease management items were very much underutilized. So this slide shows us that the total claims for chronic disease management items, such as care plans, fell really dramatically, despite the telehealth item numbers being available. So on the next slide, just showing you the same thing happened with health assessments. Those numbers also declined dramatically. Part of this is because the only telehealth item number for health assessments that was retained during the pandemic was the Aboriginal and Torres Strait Islander health assessment. But on the other side of the coin, that this gave us a great opportunity to provide comprehensive Aboriginal and Torres Strait Islander health assessments to people who we might not have done that with prior to this pandemic. On the next slide is some statistics that came from Hunter New England Central Coast PHN survey of general practices that also revealed that there was a significant impact on the workforce. So this decline in face-to-face presentations in general practice, the workforce was associated, I think, with a serious impact on the workforce. And the part of the workforce that was very dramatically affected, as shown on the next slide, were nurses. This is a slide of Professor Liz Halcombe down at Wollongong University. She and some of her colleagues surveyed nurses employed in primary care across Australia. Of the 637 nurses who answered the survey, nearly half, almost 44%, reported a decrease in their hours, as well as threatened or actual loss of employment. On the next slide, you can see that the Australian Primary Care Nurses Association also did a survey called a Pulse Check, and more than 1,000 nurses responded to their poll. 31% of them reported that they had their paid hours reduced, 7% had their employment terminated, and 27% indicated that their employer had discussed potential loss of paid hours or job termination. So incredibly, this is happening in the middle of a health crisis when nurses are needed more than ever. So what is the solution? I'd like to have on the next slide, have a look. What we need is a different funding model for general practice. That's a given. And APNA and other peak bodies are working with government to try to change policy around this. But we definitely need a funding model that recognizes nurses' contribution to the healthcare team. The community certainly respects our profession, and we're consistently rated the most trusted profession in Australia. But that's no consolation to those nurses who are losing work on the front lines of healthcare. So I think and I hope very sincerely that coming out of COVID-19, that there will be a better appreciation of the role that nurses play in the team and more nimble ways of funding nurse activity. Now, just coming to the issue of practice revenue that can impact on nurse wages, I want to talk about that for a few minutes. So if practice revenue is not high enough, then we as practice teams need to go and look for the patient populations that are probably ignoring their care at the moment. That can include the elderly who are frightened to come out during this pandemic, or people with preventative health issues that are necessary, breast screening, cervical screening, so on, that people have suspended, or that population of people with a very high chronic disease burden who we know are at risk during the pandemic. So what I'm suggesting is that if patient volume is the problem and revenue is the problem, then we need to go looking for patients that we serve that need our help, that are not reaching out to us, and we need to reach out to them. That's why a different service delivery model than what most of us are used to is necessary. But I reckon nurses are well and truly perfect for the job, and here's why. The APNA Workforce Survey, which is an annual survey that's done, and also just a plug for APNA, if you're not a member, please join. They are the only peak body that's really strongly advocating for nurses in primary care. If you're not going to join, please fill in the workforce survey when that invitation comes around to you every year, because that really helps us to keep a handle on what's happening with nurses and the workforce in primary care. But back to the national survey. So the summary report for the survey that was done earlier this year was released on International Nurses Day. And on the next slide, one of the key findings from the survey is about the underutilization of nurse skills, which really represents a significant lost opportunity for the Australian health system. Of the nurses surveyed, 45%, nearly half, told us that very often, or most of the time, their knowledge and skills weren't being fully utilized in their current role. Nurses want to do more. So what's the holdup? Let's go to the next slide. The majority of nurses who were asked if they could undertake more complex clinical or extended tasks in their role were not successful in their request, as you can see by the bar graphs at the bottom of the slide. So if you want to do more, be proactive and ask to do more and try to figure out how that would look. Now, there are a lot of resources that can help us with this. So the PHN, and I'll talk more about that in a few minutes, APNA, and lots of people very willing and able to help nurses to extend their role in primary care. Some things to think about. Are you interested in working with teens? Do you want to set up a teen clinic, or you have a strong interest in working with the aged people in aged care, or you're interested in helping with the aged care assessments, or a dementia clinic? You could set up, some nurses in other parts of the country have set up a dementia clinic, or a women's health screening service. Or if you're really passionate about healthy lifestyle or weight loss, set up a service so that patients can access your expertise. On the next slide, you can see some of the roles that nurses have taken on in their practice according to that workforce survey. So nurse immunizers, cervical screening, chronic disease management. Some have become expert asthma or respiratory educators and diabetes educators. So there's a lot of talents and skills out there. On the next slide, there's a slide. If you're a practice manager or practice owner, review the scope of your nurses. What could your nurses be doing to assist your GPs with their current workload? Are you really using team-based care? Are your nurses working at the top of their scope? Do they need further education or support to work with GPs collaboratively? There are some amazing resources around all of these topics. Ask yourself if your nurses are doing stuff that could be done by admin. There are so many things that nurses can do, and I think it's sad when nurses lose their hours, lose their jobs, because we can't see a role for them. There are so many things that nurses can contribute to. So on the next slide, just a bit of a longer list. I put the hashtag nurses can do stuff at the top. Some of the things just before I left for TI that the nurses at Qatar, where I work, were involved in were COVID risk identification and screening and triage, implementing and overseeing quality and infection control, all the things that John just talked about. Nurses are really good at that stuff. Coordinating flu clinics, care planning and chronic disease management, including utilization of telehealth. And there are some slides on that, a few more slides further down. And then proactively identifying and contacting at-risk patients to ensure ongoing routine care is happening. Relevant business activities such as policy and procedure development for the practice, working towards accreditation, which is still happening in the background. Data cleansing and uploading to My Health Record, staff education and support. So there's a lot. There's just a lot that nurses can do. Just to talk for a second about the chronic disease care planning, if you go to the next slide. Now, this is a recently released APNA publication that you can access on their website. Just a summary of the chronic disease care planning is one practice team activity that really should not have been put aside during the pandemic. Later on, I think Sarah's going to do a presentation in a bit about how that work can be even more important during that time. And on the next slide, as I said earlier, if patient volume is your problem and revenue is the problem, then we need to go looking for the patients that we serve that need our help, that are not reaching out to us. So we need to reach out to them. I really have to turn this phone off, guys. I'm so sorry. That's the family at home wondering how I'm going. Got to turn the family off. So if patient volume is your issue, we need to proactively reach out. And this is the item number that supports us to do that work. So it can be done via video conference or telephone. Same item numbers, the 10997 has just been replaced by the 93201. And it's great that that item number is there for nurses to support patients with a chronic disease. So if we could go to the next slide. The next slide is about the Aboriginal and Torres Strait Islander health assessments. COVID-19 is a really serious public health risk for Aboriginal and Torres Strait Islander people. Intergenerational trauma and injustices are associated with long-standing health disparities. And particularly those over 50 are at increased risk of severe COVID-19. So the availability of this item number provides a great opportunity for us to reach out to this really vulnerable population via video or telephone. And we've had great success with doing that at Qatar Family Practice. On the next slide, so just a summary on the next slide of those item numbers that are available. Please use these telehealth item numbers to provide support for patients through health assessments, care planning, and chronic disease management and support. There's just two more financial considerations that I want to go over before I hand over to one of my colleagues. And on the next slide, the Workforce Incentive Program, this is just a summary, a quick reminder that practices are eligible for payments up to $125,000 a year under the Workforce Incentive Program, also called the WIP. And this is for practices who employ nurses or other allied health professionals. If those practices reduce their nurse hours or allied health hours, then their payments may be reduced. And finally, the last slide, the Practice Incentive Program QI, Quality Improvement Incentive Payment, provides up to $50,000 per year, and many nurses are really actively involved in contributing to quality improvements at their practice. The PIP QI has been doubled for the May and August quarters, and to be eligible, practices must be open for face-to-face for services for a minimum of 4 hours a day, or for part-time practices, it's 50% of their normal operating hours. The PHN has an awesome primary care support, PCIO, improvement and support team who are ready, willing, and able to help you with implementing quality improvement in your practice. So thanks again for tuning in tonight. I really hope that Telstra didn't let us down with this transmission, and I'll now hand over to the next speaker.
Thanks, Denise. The quality of the visuals is impressive from Thursday Island, so thank you very much. It's very stable and we've managed to hear you very clearly, so very much appreciate it. Now going to hand over to Sarah Houlihan. Sarah's a Digital Health and Primary Care Improvement Officer in our Digital Health and Primary Care Improvement team. And Sarah's going to talk about considering the social determinants of chronic disease management, especially during a COVID-19 pandemic. Thanks, Sarah.
Thank you. And Denise, you've of course led a very nice segue into discussing chronic disease management. I'm probably quite fortunate that my primary care experience in practice has mostly included nurse-led clinics. So I've really seen the value of how nurses can really be involved in leading and also assisting GPs with getting that comprehensive care. When the COVID outbreaks began in Australia and really started to impact on our regions, we know that our vulnerable patients were told to self-isolate. Combining that with their worry about overburdening the health system, like we saw on Denise's slide, we needed to think outside the square. Some of the usual things that we were used to doing, so relying on their pathology results or just doing their physical assessments, weren't available anymore. So when we started to dig a bit deeper, we realised that we needed to ask them more about their holistic care. So we began with discussions around the social determinants of health. Originally, these were things like access to suitable food for their chronic disease, their access to transport, where carers may not have been available, or those who were previously accessing community transport or public transport. We had to consider that a lot of these patients were suddenly unemployed, may have had financial concerns, which could affect their medication use or access to care. As you'd expect, this tool that we originally devised, it's been revised and updated multiple times because as the local climate has changed, so have the needs of our patients. We designed this template at the PHN and it has been shared and used quite widely in practices through social media networks and also as some learning tools. It's not designed to be a checklist or prescriptive in any way, more a series of prompts in things that we need to consider regarding our whole patient and developing a patient-centred plan of care. So when we empower our patients to identify what's important to them, we help them set realistic goals, they're more likely to take positive action to proactively manage their own health. So making positive changes to chronic disease management, of course, requires for us to have, as a team, approaching chronic disease management with an understanding of the role that each team member plays, but also the value of planned care. Having those discussions with our patients that this isn't just a once a year, come and get your 5 free visits and off you pop. We want our patients to be engaging with us regularly. We want to be able to keep engagement with them so that when things do start to change, or if they have concerns, that they know that they can rely on us. We need to look beyond the most obvious chronic condition and consider the history behind it. Is this a genetic predisposition? Is it lifestyle, economic, social, cultural factors that may have potentially contributed to the development of the chronic disease in the first place? We also need to identify the comorbidities and potential risk to the patient and provide them with education so that they can feel involved in their own care. So, backing up what Denise said before, comprehensively managing our patients with chronic and complex diseases provides remuneration around 3 times greater than that of a single annual health assessment. We place a lot of emphasis on doing our health assessments for our over 75s, our 45 to 49-year-olds. But in this instance, we're talking about regular contact with our patients, utilising not just the 721, 723s, but their reviews, their 10997 nurse follow-up items, and seeing these patients, routinely every 6 to 12 weeks. I would encourage you to get your practice together, have a chat about how you might be able to have a look at the way that you're approaching your chronic disease management, and identify if there are any changes that you may be able to make. So whichever way you feel might work best for your practice and your patients, I hope you may be inspired to think about some more holistic and patient-centred care plans for your patients with chronic, terminal or complex health issues. Thank you.
Thanks, Sarah. Appreciate it. We're now going to really test the technology, and we're going to cross to Andrea McClymont and Donna Block, who are actually in Moree tonight. So we're sort of getting around the country a little bit, trying to see what we can do to make our live streaming technician earn his pay. So over to you, Andrea and Donna. Thank you. Andrea and Donna, you're on mute, so you might want to take yourself off mute. And that's very unusual for Donna. Do we have Donna and Andrea? No, we've lost them. All right, we might do a quick swap around and go to Pat Cashman while we try to re-establish connection with Donna and Andrea in Moree. It's a little bit ironic that we managed to get to the Tiwi Islands, but we can't reach Moree. So just going to introduce Patrick Cashman. Patrick's the immunisation coordinator for 100 New England Population Health, and Patrick's going to give us a bit of an update on immunisation and answer a couple of questions that have already come in through Slido. Thanks, Patrick.
Thanks, John. G'day everyone, how you doing? That's great. We've got folks from Thursday Island and Moree. Fantastic. Hopefully we'll get those 2 wonderful people from Moree up on the screen. So we know that this year's just been pretty ho-hum for everyone, so we thought we'd introduce some immunisation changes on the 1st of July. just to change things up a little bit. So these are quite important. It's quite a big change on the 1st of July coming in. The main changes are in the funding. So now we can give some vaccines funding to people. It wasn't funded previously. So that's pretty exciting. So the diseases which it affects mainly are bacterial diseases. So pneumococcal disease, meningococcal disease, all the varieties of meningococcal disease, Haemophilus influenza type B, and hepatitis A. Now, hepatitis A changes will only affect those in the NT, WA, South Australia and Queensland. I normally wouldn't mention it, but for Denise's benefit, hepatitis A vaccines, the schedules, time points are changing for Aboriginal kids up on TI, Denise. So the pneumococcal changes, you remember the current list in the handbook are 2 risk categories, high risk category A and lesser risk category B, and quite complicated to tease out where your patient sits and whether they get funded vaccines or not. So from the 1st of July, there's just one condensed list of risk conditions for pneumococcus. So this is a nasty bacteria. So this is trying to protect people who are at risk from invasive pneumococcal disease. Now there's a lot of conditions that are recommended to have the vaccine, but it's only funded for some. Now the big changes are that some people who it's funded for from the 1st of July is bigger. Another change is that the Pneumovax 23, the polysaccharide vaccine, it's now limited to 2 lifetime doses. So if you've had 2 doses in the past, that's it. You don't need any more. So if you look at the AIR and someone hasn't had 2 doses, then you can get them up to 2 doses. But if they've already had 2 doses, that's sufficient. They don't need any more. So these are the pneumococcal changes schematically, and that one of the aims of ATAGI and the handbook when they were making these changes was to better protect people who are vulnerable, but also to make the changes a little bit simpler for providers. So on the left-hand side there is the Universal Childhood Schedule for all non-Indigenous children. And in New South Wales, we give a Prevnar 13 at 6 weeks of age, 4 months of age, and 12 months. That's what we currently do. The next box to the right is for at-risk children, which is kids with medical conditions and Aboriginal kids living in New South Wales. So that's, no, not Aboriginal kids in New South Wales, that's kids who are at risk. So that's Prevnar at 6 weeks, 4 months and 6 months. So they get an extra Prevnar at 6 months, the usual one at 12 months. And then this is the change. So 2 doses of Pneumovax 23 at age 4 and then 5 years later. So that's the change for sick kids starting under 12 months. Then kids who are over 12 months of age, they get an extra Prevnar at diagnosis and then a Pneumovax 23 at least 2 months later or at 4 years of age, whichever's later, and then a second Pneumovax 23 5 months after that. That's not a big group of kids, but that's kids who are crook. Now the big change is for Aboriginal and Torres Strait Islander adults without a risk condition. So this is the second row from the right-hand side. So this is new, this is brand new. So that is getting a Prevnar 13 at age 50 for all Aboriginal adults. So they don't need to qualify with a risk condition. This is all Aboriginal adults. A Prevnar, which is the same vaccine you've been giving to kids, we now give to Aboriginal adults at 50. And then a Pneumovax at a year later, and then one at 5 years later, then that's them done. And the second big change, at the moment, today, we give a Pneumovax 23 to everyone who turns 65. That now stops from the 1st of July. That now changes to 70, and they just receive one Prevnar 13. So that's quite a big change. Now there's a few questions going to come out because that's right across the whole population. A few questions there. So if someone's 66 or 67 now, they've already received their Pneumovax 23. When they turn 70, you just give them a Prevnar, and that's all you need to do. So they've already had a Pneumovax, you just give them a Prevnar. If for some reason they've had a recent Prevnar, they don't need another one. But for most people turning 70 from the 1st of July, they'll need a Prevnar. So that's a new change. Now that's the same time that the funding for Zostavax happens. So you can give those 2 vaccines at the same time. So for people who turn 70, you can give them a Zostavax and a Prevnar 13. Now the reasons for this is, the reasons they've added the Pneumovax 23 for Aboriginal kids is because a lot of the serotypes of pneumococcus that affect Aboriginal kids aren't covered in the 13 valent. So the 13 valent's a superior vaccine, a conjugate vaccine, it's a better vaccine, but the serotypes are covered in the 23 but not the 13. So that's the reason bringing that in for Aboriginal kids. And for older people, these vaccines don't last forever, but the risks are more concentrated in the older population. So it's better to delay giving it at 70. Very few people get these diseases, invasive pneumococcal disease, between 65 and 70. So delay it to 70 so it'll last longer into their older times. And then give those 2 vaccines at the same time. The new Prevnar 13 and the Pneumovax 23. So there's some specific changes for Aboriginal kids, some specific changes kids with risk conditions, and some big changes for Aboriginal adults at 50 and for the whole population at 70. So from the 1st of July, we'll stop giving the Pneumovax 23 at 65. So you can all make your retirement plans, but you won't get a free Pneumovax 23 at 65. You'll have to wait till you're 70. What's that? You practice nurses? You're not paid very much? You're not going to retire to 70 anyway? Okay, all right, well at 70 you'll be able to get that. The other big change for meningococcal B is for Aboriginal children, the Bexsero vaccine, which is the meningococcal B vaccine, will now be funded for all Aboriginal kids across Australia. So this is terrific. So Aboriginal kids, the burden of meningococcal B disease falls much more heavily on Aboriginal kids. So now this will be funded at 6 weeks, 4 months and 12 months. So this is quite exciting. There'll be a catch-up for 2 years until the 30th of June 2023 for kids up to 2 years of age. So if you do have Aboriginal patients that you're looking after, put in a recall for kids that are about 23 months old or so, because they'll qualify for that after the 1st of July, but once they turn 2 they won't qualify for that catch-up. So this is quite an exciting change based on the epidemiology and the risk. And you think about what's happening with people wanting to do something about Black lives. This is something we can really do, really important, is to save Aboriginal kids. So that's absolutely fantastic. Now this vaccine, you know, increases the chances of fever. So what we don't want is to give a kid a vaccine, mum takes them home and they have a febrile convulsion. So this vaccine, it's recommended to have paracetamol before the vaccine and then 2 doses 6 hours apart after the vaccine. Now this vaccine's been given on the regular childhood schedule in the UK for several years and they haven't had problems with febrile convulsion afterwards. They do use paracetamol, and it's been used in South Australia, which has a big Aboriginal population, for about 12 months. There hasn't been a problem there with febrile convulsions, but we really need to give people good advice. And for parents who miss this vaccine, it's not in the calculations for no jab, no pay, so there's no penalty there. And I love this movie. I remember seeing it when it was released in '37. So you know the story of the guy with no brain, no heart and no spleen. So for no spleen, they miss out on everything apart from being in this terrific movie. But now the Commonwealth Government are going to fund vaccines for people with no spleen. So that's absolutely fantastic. So now meningococcal B, Haemophilus influenza B, the bacterial diseases, and if you haven't got a spleen, your ability to fight bacterial diseases is much decreased. So now these vaccines will be funded. Up to now, they've had to be self-funded, and they're very expensive vaccines. So this is great. So you'll find you've got some patients that don't have a spleen. You'll be able to put in a recall after the 1st of July, bring them in and give them these vaccines that they haven't been able to afford to have up to now. So this is fantastic news. We've been pushing for this for some time. Yeah, so that's absolutely fantastic, and it'll obviously apply to people if you're in a surgical situation, people who've lost their spleen traumatically. Now, as practice nurses, you'll know you don't have this problem. The next problem where you get free funded vaccines is complement deficiency. Now, you get complimented all the time, I'm sure. I'm sure all the GPs you work with and all the patients and everyone loves you. You're getting compliments all the time. But for patients that do have a complement deficiency, unlike you guys, that also will increase the risk of meningococcal disease if you haven't got enough complement, because complement's part of your immune system. That's also free and funded. And the monoclonal antibody eculizumab is also will decrease, thank you. I get some pronunciation lessons from you when I come and visit your practices, when we're allowed to do that again. That will also, will lead to, the reason we give that monoclonal antibody is because there's a problem with complement, and that will block complement, which will leave a deficiency So you also have problems with your immune system, therefore you also have a risk of meningococcal disease, and it's funded. So for those 3 groups, just remember complement problems and no spleen, you get free funded vaccine now. That's great. Now there's 2 other groups you might expect that they'd be funded, which is people with HIV and people with stem cell transplants. Now they haven't done the cost effectiveness in those groups, so they're not funded at the moment. So just those 3 groups for meningococcal vaccines at the moment. So these are adults and children. So this is great. Now Spleen Australia have a wonderful website that they've just done up, and there's a great flow chart on there for different age groups for the vaccines they require if you don't have a spleen. So if you do have any spleen patients you're looking after, people without a spleen, remember the Wizard of Oz, and it's really worth printing that out and putting it with their notes or taking a screenshot and putting it with their electronic notes, because that flow chart is really, really instructive. You just Google Spleen Australia and it's a brand new website, and you'll find those flow charts there, and they're really useful clinically. There's lots of useful information. The handbook, the electronic handbook, I still can't get used to it. I still want to thumb through a real book. But one of the advantages is that resources can be updated. There's some great infographics in the new handbook, really worth having a look at. And there's some rippers there with this new schedule changes that's worth having a look. Now, if you want more detail, there's more detail on these schedule changes. On the 14th of July, which history buffs will know as Bastille Day, so think something French. No, not people dying of COVID, I meant something more joyful. Bastille Day here in this place, the PHN are very kindly going to host an hour about the new changes. We've got some guest speakers. So that should be good. So that's something to look out for. So one of the questions that came in about people doing their regular immunisation updates, so part of being an immunisation nurse is knowing what's going on. And we usually do an immunisation update, and we do that face to face, and it's well, I have a lot of fun. I don't know about anyone else. But we did do one of these earlier in the year, and that's still up on the PHN website. So if you've missed that, you can just go back through these sessions, do that, and keep your own record of that, so that it shows that you've been up to date this year. All right, fantastic. Thank you very much, everyone. Thanks, John.
Thanks, Pat. We've got a whole host of additional questions, but we'll come back to those at the end of the session. And if we don't get time to cover those, you will be able to find them on our website in the summary of today's session. So we're now going to cross to Andrea McClymont and Donna Block, who are joining us from Moree, and hopefully the technology works this time. Thanks, ladies.
Hi guys. Hi. Right, over to you. Okay. I'm a registered nurse with Associate Medical Practice in Moree. My first go at a presentation of a webinar. I'm a bit nervous. I'm relatively new to general practice. I've only been in the game for about 8 months, and I think I've learnt more in that last 8 months than I've learnt in my whole entire 18 years of nursing. COVID-19 has certainly thrown some interesting challenges and changes our way. During the first few days and weeks, it was a struggle to grasp all the changes. Change fatigue and information overload was a real issue. From a rural practice perspective, we were lucky we do not live in a densely populated area, so social distancing is much easier out here in the sticks. But we still had our fair share of problems. For example, a COVID test result can have a turnaround of 3 to 7 days. Delivery of education changed, the way we went about our business changed, the way we interacted with our patients changed. Webinars on infection control, telehealth, COVID-19 came at us thick and fast. In the practice, we implemented heightened infection control practices, physical distancing measures, and shifting to telehealth consults to adjust our services during COVID-19. Whilst these changes initially caused some chaos, everyone quickly adapted to the new norm, and this is now settled. In the consult rooms, we packed all our equipment away from the countertops, removed magazines and toys from the waiting room, placed signs on the front door and throughout the waiting room in regards to physical distancing, set up a hand sanitisation station at the front door, placed a barrier in front of reception, and separated seating in the waiting area. The workload for reception staff increased tenfold. Their daily routine now consisted of wiping chairs, surfaces and door handles several times throughout the day. The phones were ringing non-stop. I would say 98% of these calls were in relation to COVID or flu vaccines. We had the media and a rumour to thank for all the hype. Our local paper printed a story with the headline, "Get your flu vaccine now before you end up with a double whammy." At the time of print, we had no flu vaccines in stock. One of our doctors was off sick, so the local rumour mill diagnosed her with COVID. We were accused of being liars and told that we had a right to inform the public of the truth. With COVID-19 hitting us at the beginning of flu season, we had to implement an innovative way to deliver as many flu vaccines as we possibly could in a short period of time. We had to ensure physical distancing, correct infection control measures, and minimise large volumes of foot traffic through our practice to protect ourselves and the community. We were very lucky to have an external ambulance door in our main treatment room. Outside this door, there is a covered walkway which leads to the undercover car park. This was the ideal area to set up our flu clinic with a table for the receptionist and several chairs for the patients, and they would be protected rain or shine. It also meant we did not have to move equipment or vaccines as we were still working out of our treatment room near our vaccine fridge. Seating was placed socially distanced. We had wireless EFTPOS for those who needed to pay. The receptionist would time each patient for 15 minutes post-vaccination. Hand hygiene and flu clinic signs were well displayed on the front fence and carport posts. We managed to get up to 130 patients vaccinated in a day. All up, we've vaccinated over 2,000 against flu so far this season. The clinics ran very smoothly and the patients thought they were great. After a few weeks in isolation, the patients treated it like a big social outing, sitting about chatting. It was difficult to get them to leave after their 15 minutes. We ironed out and tweaked issues that arose as we went along. One of our bigger issues was country folk, being the ever-friendly people they are, would walk into the treatment room, sit down, chat, ask about test results, etc. For the clinic to run quickly and smoothly, we had to implement rules on a sign and a sticker with a cross in it just through the treatment room door on the floor, informing the patients to stop and not enter any further. PPE shortages did not miss us either. For nurses, the lack of protective equipment in the fight against COVID-19 has emerged as a major issue across the country. We are still waiting on delivery of an automatic hand sanitisation station, which I ordered in March. We had one box of masks, which were only to be used in extreme circumstances as we could not source any more. When our hand sanitizer started getting to critical low levels, I began phoning the supermarkets begging for it. I borrowed some from my daughter, who manages a fast food restaurant. Woolies sold us 10 by 250 ml bottles. That's all they had. Coles promised that on their next delivery, they would sell me what was left over after the hospital got what they wanted. At this point, I realised how bad things were when the hospital had to buy hand sanitizer from the supermarket. We have always had that safety net of knowing that we have access to what seemed like an unlimited supply of PPE. Now stock levels have returned to almost normal. I am making sure we have enough supply of everything we need and will also need going forward. My job probably hasn't changed, but people's awareness of what I do has changed. I have had so many more people reaching out to me and checking in with how I'm going. As a nurse, that's not something that we're really used to. We're usually the ones looking after everyone else. It is the unknown of not knowing what is coming. We are not sure what is going to happen, so all we can do is prepare for the worst and hope for the best. We have had patients in a business house drop off gifts and flowers, saying how proud they are of us and how they appreciate everything that we are doing. it is just nice to know that there is community support for us. During this time, we still had a responsibility to continue to care for our patients, particularly our most vulnerable, and look after their physical and mental health. While doing our GP management plans via telehealth, we were educating patients in infection prevention, strategies to reduce anxiety related to COVID-19, self-management during isolation, ensuring they had access to necessities and food, and staying connected with their family, friends, and health professionals. We worked closely with community health nurses to attend our flu vaccines for the most vulnerable that could not leave home. Of course, these patients were already being visited by community health nurses for other reasons. One of our GPs visits our local aged care facility on a weekly basis. We did not want to place these vulnerable patients any further at risk, but knew we needed to continue our service to them. I had the registered nurses from the aged care facility email a list of what was needed to be done for which patient. From this list, I triaged what could be attended from the practice by the GP. This cut down on the time the GP needed to spend in the facility. Nick, one of our GPs, was in isolation after travelling to see his parents in the UK. During his 2-week isolation period, he worked from home doing telehealth appointments. Our practice manager, Judy, would deliver and pick up the paperwork from him. Mayel, another GP, was on maternity leave, but she offered to do telehealth appointments for us too, which took a lot of the pressure off. Our local confirmed case had been in our practice. The first we were made aware of it was when we received a phone call from Public Health. Public Health were very thorough and efficient in dealing with the situation and contact tracing. The doctor involved was sent home immediately and isolated. The room was extensively deep cleaned. Video footage was viewed to identify anyone else that may have encountered this patient. It ended up this case was not locally acquired, so I am proud to say Moree remains COVID-free. It is thought the patient contacted it elsewhere outside of Moree and after their visit to our practice. We have seen incidents of mental health related cases in the past few weeks that are a direct result of isolation and border closures. These patients were suffering from not having personal contact and being able to cross the border to visit family. Our community and patients have now become more relaxed but remain aware of social distancing and hand hygiene. Thanks, guys. And I'll hand you over to Donna.
Slide in, slide out. Thanks, Andrea. So I have a presentation for you that Todd is going to put up for us. So I've been asked to present a few case studies together for you tonight, and they relate to a presentation we're actually doing in a couple of weeks called Patient Journey, which is essentially about pulling the practice team together for the benefit of the patient. Traditionally, in general practice, we tend to work in silos. I think Denise alluded to it very well, how the priority of the patient needs to be coming first, and we need to use our admin and our team to work together. She didn't see me, but I was actually sitting here cheering. So the aim of the patient journey presentation is to have the team all working on the same patient goals and developing processes within the practice to enhance the patient experience. We will present the same case studies tonight and in the next fortnight, so you can get a chance to consider working this way in your practice and encouraging your whole team to participate. So if we could go to the next slide, Todd. Practice nurses work with chronic disease patients in developing GPs and TCAs as a major part of their role, along with preventative care in the form of health assessments. We're going to look at a couple of case studies. And so the first one we're going to work with is Mrs. Gray. She's just turned 45. She's a diagnosed diabetic and has presented to the practice for renewal of scripts. So what do we think that we might be able to support her with? So if we just pop up the next slide. So as you will see, I come from a practice management background, and so I make no apologies for being very aware of how the practice needs to stand financially. If we don't have a service, we don't look after patients. So we need to be viable. And I think the most important people in that role are our clinicians, of course, and our practice nurses who play a vital role in this. So for this patient, I've chosen to look at a few different ways of looking after them. Of course, they wouldn't qualify for a health assessment for a diabetes risk evaluation. She's already got that. But she could qualify for a heart health assessment. I haven't put it in there, but it's just something I want you to consider. She's also possibly eligible for a 45 to 49-year-old health assessment going forward. And I've chosen that one in this example, but you might like to play with that, work out where that works for that patient. She's eligible for care plans, TCAs, reviews of those, 3 in a 12-month period with a care plan in place. Yes, the care plans and the TCAs are valid for 2 years, but they can be redone after 12 months. I've worked with a 12-month option here. That will be a decision that sits with your GP. The review process can be done every 90 days. So that means there'll be 3 in that 12-month period. And along with the practice nurse item numbers, they're entitled to 5 of those visits in between with the nurses. We could do a diabetes cycle of care. We can consider other services that the nurses will be happy to do on behalf of the patients when directed by their GPs, ECGs, home medication reviews, so very important, and even ABIs. And if we're doing all that work, there's a bonus if you're doing that, if you're bulk billing these items that add to that. So you can see there's a significant number of bulk billing incentives added to that patient journey. And so over the 12-month period, this patient's generated a significant amount of income for the practice, and that's just one patient. And as I like to say, she hasn't had a cold, she hasn't broken her arm, she hasn't done anything, but we've looked after her very significant and important disease that affects her life quite significantly. So moving on to the next slide. This gentleman is an Aboriginal patient, Mr. Collins. He has a very significant family history of stroke, cardiovascular disease, cancer and kidney disease. He smokes, he drinks, he's obese, but he's recently had a diagnosis of COPD. His life is about to change significantly, I would assume. I'm not clinical, I'm going to assume. So if we have a look at what happens for Mr. Collins in the next slide. So again, we have a significant body of work if we look at the journey for him over the next 12 months. Now, I'd just like to draw your attention to his Aboriginal health assessments. I've actually put 2 in there. The reason for that is very, very clear when you read your MBS schedule. It is an annual health assessment that can be opportunistically captured after the 9-month mark. And if that was to happen for Mr. Collins in that 12 months, he would actually have 2 of those health assessments. What is also significant to go along with that is that the follow-up with the nurse, though, still only sits at 10 items in that same 12-month period because it is run by calendar months and they tick over from January to the next one. He would qualify for care plan, TCA, reviews of both of those every 90 days, follow-ups with the nurses as well too. If he's in a rural area, he's going to have a serious amount of bulk billing incentive added to that too as well. He could probably benefit from a 6-monthly ECG because of his family history. I've also highlighted there the Holter monitor. I haven't actually added it in because it's not necessarily a piece of equipment that a lot of practices in our area that we experience have access to that in their practice. It's usually something that gets referred off-site for. But if you've got that piece of equipment, that is definitely something that you could use on behalf of your patient. Again, a HMR to see what the patient's using at home. The spirometry, his new diagnosis is COPD. We should have 2 spirometry item numbers these days. We have a monitoring one and a diagnosis one. So I've added in one of each of those, and I've also included an ABI. And again, Mr. Collins hasn't done anything else. He hasn't even had so much as a flu shot appointment, a script appointment, hurt himself significantly any other way. All we have done is look after his chronic disease and also the fact that he's an Aboriginal patient. We've taken good care of him. And again, he contributes significantly. These 2 chronic disease patients, there are 2 examples that would be very typical in any practice, but I'd like you to consider how many of those you actually have in your practice. And if you've got no idea, you have access to a tool, the CAT4 tool that comes from PenCS, and you can look across the various disease streams using that tool and have a look at the patient load that you actually have with a diagnosis in place for your patients. Again, relying on the coding of the doctor to actually have that in the software in the right part so Pen can find those patients for you. And you'd be quite surprised at the disease burden that you would find in your practice. And these are all patients that the GP might like to consider to actually putting onto these care plans to manage their health journey so much better. Of course, it always starts with the GP's decision to place the patient on this care. And if you need help in working out how to use the pen so that you can actually find the patients, that's what your friendly PCIO officer is here to do. We love to come and talk about data and how you find patients and how you treat them and what else can you do for them, how can you work with your nurses better, how can the admin team provide support. So consider making use of us. We're glad to be there and be part of the journey. So if we can go to the next slide, thanks, Todd. So this is my passion. This is my reason for why I think this is important. I want you to think about this in terms of if we were talking about a member of your family and how would you like them to experience their healthcare journey through the practice they attend. And I call this slide my 15-minute GP consult. So if we talk in terms of a standard consult, it pays a wonderful amount of $38.20 and the patient comes and their immediate needs are met until the next time they feel sick and they think they should come. The long-term health outcome may not change, and many patients with chronic disease are managed this way. They don't have the knowledge about what the alternative is. That sits with you, the practice team. The alternative is putting them on a care plan, a GPMP and a TCA. So a brand new one generates $262.70. Outcome for the patient, they have a new understanding of their health. They know they have a role themselves to play in improving this. They have a plan for their health needs that's just about them and it will be reviewed regularly. They have a team to help them meet their goals. They can come back for help and support and see our fantastic nurses between that for their reviews. And the GP would need to do 6.88 standard consults to generate the same income, but more importantly, the health gain for the patient is maximised. We've started them on a new pathway. How do you want to spend your 15 minutes? I think it's worth thinking about. So that's the end of my presentation. I'd just like you to have a think about what we've said today. And if you're interested in maybe changing the way that your team works, if you want to bring them together, we've got a presentation called The Patient Journey coming up. Please encourage all of your team to come along and listen. Thanks.
Thanks, Donna, and thank you, Andrea. Very much appreciated. Love the blue tiles in the room up there. We're going to ask a few of the questions that we've got on Slido. Can I just remind you that if we don't get through all of those, we'll post the answers up with the summary of tonight. But the first question I've got, Pat, is from Kerry Ann. Hi Pat, would Aboriginal children, if they commence on schedule prior to age 2, be covered for completion of the schedule if that happens post age 2?
Yes, they will. So yeah, if you start them off under 2, they can complete that course of meningococcal B Bexsero vaccine funded. Yep.
I'm not sure if this is the same question or a variant on it. Is the catch-up schedule for Bexsero in Aboriginal Torres Strait Islander children greater than 1 and less than 2 still dose 2 doses 2 months apart?
Spot on, correct. That's
spot on. Go to the top of the class, yes. Whoever that was. If someone is already 71, is there a catch-up for Prevenera?
Yeah, no, it's a great question. I don't think there is. I haven't seen that announced, so I think it's only for people who are turning 70 now. If you're 71, you've most likely had the Pneumovax 23 at 65, and you'll still have some onboard pneumococcal cover from that. But the new schedule is for 70-year-olds, and I don't think there's a catch-up component.
Thanks for that. Kerry Ann's been really on to Slido tonight. Hi Pat, where can I access the immunisation picture printouts to be ready for July 1. Went looking on the government website and they aren't there yet.
So the handbook, if you go to the handbook website, so just Google immunisation handbook, across the top there's a menu. We spend most of our time in the diseases chapter, but if you go to resources, you'll find those infographics in those resources. They're really useful. If you have any problems, please contact me and happy to help.
We've also got a question from Polly, and Polly asks, can you tell us when the new hard copy schedule will be available?
Great question, Polly. I don't think until very close to the 1st of July. It's not available yet. Also, information on ordering these vaccines isn't available yet, so there's some details to come in the next few weeks, but the hard copies to go up on your wall are not available yet, and I'll let you know when they're available. Most of you will receive the To The Point email we send out, the newsletters, so if you keep in touch with those, you'll find out when the latest information's available.
Thanks, Pat. That's all the questions for you, Pat, so you can breathe easy now.
Thank you.
I've got one question for John, and that... Oh, well, we'll reveal the scores at the end. The judges always save them till the end. So, John, my question to you is in relation to the recently added criteria for testing, which is about the loss of smell and taste. What are your thoughts? Any observations?
Well, look, it's certainly well described, and I think the virus replicates in olfactory mucosa well. It has the right receptors, so there's direct damage occurring to those smell receptors. It does recover with time. It can be an isolated symptom within people so that they don't suffer from anything else, and I think people have been self-diagnosing on that basis overseas. We haven't had any of our patients with loss.
I was just going to ask, any local reports of that particular...
Not the patients that I've dealt with, no.
No, okay. No. All right. Thanks for that. Those are all of our questions. That's all of our questions. So thank you very much, John, Pat, Sarah, Denise, Andrea and Donna. Very much appreciated. Can I just do a couple of things? If I can get you to complete the poll on Slido, which is PHN9, and also do a bit of a plug on a couple of things. We've got the upcoming immunisation webinar on Bastille Day. And also, can I suggest that those of you who have an interest in quality improvement, in particular in QIPIP, might want to consider joining our community of practice, and you can do that through our People Bank site. If you go to our normal website and follow the links, you'll be able to participate in our QIPIP community of practice. Thank you once again to all of our speakers, very much appreciated, and I wish you good night. Thank you.